Welcome back, everyone, and thank you for joining us for session 2, Current Areas of Impact in AI. My name is Elsie Ross, and I'm a vascular surgeon and data scientist at Stanford University. I'm extremely excited about this session. As someone who's been in the trenches of healthcare for over 10 years, I've seen innumerable ways in which AI can really transform care, helping us provide safer, more precise, and efficient care for our patients. In this session, we're actually going to dive into real-world examples and show that AI in healthcare isn't just hype, but we're getting real results today. Our first speaker is Dr. Jason Fries. He is a research scientist at Stanford University Center for Biomedical Informatics Research. His research explores machine learning in healthcare, focusing on methods for creating and shaping training data. He previously completed his postdoc in computer science at Stanford, where he collaborated on development of weak supervision frameworks known as Snorkel. He received his PhD in computer science from University of Iowa, where he studied computational epidemiology and NLP methods for syndromic surveillance.
Thank you so much, Elsie, for that great introduction. So today I'm going to be presenting on this idea of data-centric medical AI with weak supervision. And so I'll open where Andrew Ng started this great symposium today. And just note that ML today is very model-centric. There's been a lot of recent publications on sort of the proliferation of COVID models and how they haven't really made any contribution to value in healthcare. And a lot of the blame list is laid at the foot of what are so-called Frankenstein data sets that are generated in really problematic ways. But what this also does is it reveals a big cultural problem in ML more generally, where we overvalue novel model architectures and really undervalue systematic, repeatable data workflows. And what this creates is a culture where labeled data sets are actually barriers between experts, where ML experts assume data sets aren't to be inspected or interrogated or changed when you're building models. And so this has led to a new sort of idea, and a lot of recent really great publications around this idea is that we should do more data-centric AI. And this jives with the intuition that many practitioners of ML have, is that you get better gains in your absolute model performance from better data than necessarily fancier model architectures. And what this underlines is that ML ops as a field is immensely crucial, and that we need better methods for developing training sets, maintaining them and debugging them, and that this applying a systematic process to this idea will result in more reliable deployed models. So the issue with a data-centric view in medicine is that if you approach things in a traditional way, where you have manually labeled data, this is very difficult in medicine, where our problems require considerable domain expertise and are very expensive to scale. And the resulting artifacts are static. They're hard to change or revisit if we want to update our assumptions or broaden our scope of an ML model. So for the past couple of years, we've been exploring ways to approach labeling a little differently by doing programmatic labeled training set construction. And the idea here is that instead of having domain experts label specific instances, we collaborate with them to design rules that label data and capture certain aspects of their thinking and domain expertise as applied to subsets of data. And this allows us to programmatically generate training sets for feeding into models. And the advantage of this is that when we expose this sort of under the hood thinking of what actually goes into making labels, we can start reasoning about this process more systematically and start modeling its structure. And we can think about things like noise and disagreement and how to sort of principally arrive at a notion of a consensus. And this is the idea that underlines the framework Snorkel, which was developed here at Stanford in Chris Ray's lab, and many of the other more recent approaches to weak supervision that have come out in the past couple of years. And so the rest of this talk is really our experiences with programmatic label and data-centric AI across several different medical modalities. And this isn't a total talk. There are lots of other great examples in this, but we'll just focus on our personal experience in clinical NLP, medical imaging, and structured EHR data. So with clinical notes, a very common use case is to transform them into some structured representation. And we might want to do this to generate labels for imaging or do neat NLP tasks like visual question answering. And the process is really framed often as defining a set of entities and relations between those entities and transforming a note into some sort of computable graph. And so we were interested a couple of years ago in this idea of medical device safety. And we wanted to see how the EHR can be used to supplement our understanding of the safety of medical devices. We were very specifically interested in the idea of automatically supplementing a implantable joint registry. So we defined this entity and relation structure over clinical notes and focusing mostly on complications of specific implants and the pain at particular anatomical locations. This is formulated in NLP lingo as a relation extraction task over a set of sentences. And our question was, well, do we need to manually label a giant data set to build this setup? And we instead explored the idea of, can we generate this data set using a collection of rules put together by domain experts, and then a small labeled data set to validate everything. And so what we did is for all of these individual outcomes, we have a rule-based model, and then use that rule-based model to train a deep learning N model over 20,000 probabilistically labeled notes. And what we found is that we saw pretty dramatic improvements in performance, over a 53% improvement in F1, and really big boosts in a recall of our model, where we found 6 times more complication events than with coded data alone. And what was really attractive about this process is that it decomposes labeling, expert labeling, into modular components and provides a way to have labeling that is consistent and reproducible and provides inspectable outputs. And by thinking modularly about this problem, we can reuse these individual pieces across different tasks. And so we built a variety of abstractions around various note concepts like named entities and sections of notes and negation. And what's great is this allows us a process to which data and audit it, while also decomposing in the problem in a way that allows us to improve individual pieces. And for example, we have a paper out just this year that looks at named entity recognition and how BioBERT can be used to improve performance. We found that NER and temporality saw big benefits from using a deep learning model, but things like negation didn't see any benefit at all. We could just use a rule-based model. And so this reusable pipeline had a lot of advantages, particularly at the beginning of the COVID pandemic, when we had a lot of unknowns and questions around COVID-19 symptoms. And so we initially had this idea that maybe we could monitor symptoms and perhaps find a way to prioritize individuals that should be tested for COVID-19. So what we set up is a data feed from all Stanford emergency departments, and then looked at the first 30 minutes of anyone presenting to the ED to see what symptoms they disclosed and talked about with the doctor. And what we found is that we built a symptom tagger to analyze this, is that we actually had little ability to discriminate respiratory viruses from COVID-19, which is unfortunate from the medical side. From the technical side, our weekly supervised tagger did quite well and outperformed a baseline model by 2.3 F1 points, and enabled us to build a real-time or near real-time feed of data symptoms, which enabled data sharing for frequency information that was used in a variety of other projects. And that's one of the real big strengths of this weekly supervised programmatic labeling idea, is it lets us move very quickly. And so we had different information needs that we wanted to use. We were interested about COVID-19 exposure as a risk factor. And we were able to build a NLP model to extract this information on the order of 1 to 2 days and see performance in both over a rule model and over using nice BERT and NLP type tools. So that's for text. We're also very interested in how this can be applied to imaging. We had a problem using UK Biobank data where we're interested in identifying aortic valve malformations. We had a cohort of about 100,000 patients. The images are not labeled. It's collected prospectively, so diseases are often underreported, especially aortic valve malformations. And we had no patient notes, so we had no real way to get like a side channel of information to generate labels for imaging. And so we had a question is, well, can we write labeling rules directly over the image? This is pretty hard. Like text, we don't really have these atomic semantic units or primitives. So the question is, how can we even approach this? Well, this motivated a line of work around MRI sequence classification for particularly bicuspid versus tricuspid aortic valves. And what we did is we found that you could use fairly noisy segmentation primitives of the localized aorta to generate shape statistics about the aorta in motion. And using those to generate a few sort of features based on a small labeled data set, we're able to build a weakly supervised system to discriminate BAV from TAV. And then what we did is we generated a gigantic, over 4,000 patient training set, and then trained a model at scale where we found that training at that size provided a 62% improvement in F1. And then if we take that model and applied it to a held out set of the prospective population, we found that our model identified individuals with a 1.8-fold increase in risk of a major adverse cardiac event. And it also enabled us to generate visualizations of clustering of our assumptions of the labeling rules so that we could enable a sort of visual error analysis and check our assumptions. And so finally, another big area of importance is EHR representation learning, where we commonly want to learn a featurization of things like structured medical codes, demographics, and labs. And this is commonly done by looking at a particular target cohort and then training a model, count-based or deep learning on that small cohort. Well, this, in fact, loses a lot of advantages because it doesn't capture the structure of an entire patient population. And that's particularly important in low data settings. So a student in Nigam Shah's lab, Ethan Steinberg, has done some really amazing work building a self-supervised EHR representation learning model named Climber. It was actually trained on the entire Stanford medicine population. And then using that featurizer, you train a linear head over your cohort of interest. And what this does is it provides a very powerful for learning representations of patient timelines. And in EHR data, we commonly programmatically generate training data since outcomes are often very nebulous or they consist of various clues scattered out in the medical record. And there's good results in a recent JAMI paper last year that shows that writing labeling rules combined with a good featurizer gives you a nice way to get some transfer learning across sites. And Climber is particularly strong in basically all classification benchmarks Ethan ran, but very, very strong in small data settings, which is where we'd hope the structure would pay off. And so what we see is more generally is that we really want to get to a point where we can contextualize patient state with multimodal data. And then we need to integrate a wide range of very diverse signals from information. And the current paradigm of an end-to-end model where we have some degree of manual curation and expert labeling isn't very scalable and sort of is counter to this vision of models that can live and change and adapt to healthcare situations. And so what weak supervision and programmatic labeling argues is that we should think about how we can decompose the process of labeling into more modular and inspectable pieces that enable us to build a process by which labels are arrived with various conflicting and heterogeneous signals. This provides a lot of advantages, from richer feedback to model errors to modeling and correcting for noise or conflict, and provides a way to audit and sort of check our assumptions for how labels are generated. And this is really critical if we think more in the future of a system where we're presenting results to experts, where we want to be able to characterize the errors it's making and have doctors or other experts make fixes that are integrated in a dynamic and live way. We really need to do this with a more scalable kind of a programmatic approach. And so that is it. And this work is the result of a lot of really wonderful collaborations at Stanford during my time, both as a postdoc and research scientist here. And I would thank the AIMI for inviting me to the talk.
Thank you so much, Dr. Fries. Our next speaker is Dr. Jenna Wiens. Dr. Wiens is an associate professor of computer science and engineering and co-director of precision health at the University of Michigan in Ann Arbor. Her primary research interests lie at the intersection of machine learning, data mining, and healthcare. Dr. Wiens received a PhD from MIT in 2014, was named Forbes 30 Under 30 in Science and Healthcare in 2015, received an NSF Career Award in 2016, and was named to the MIT's Tech Review's list of innovators under 35 in 2017, and most recently was awarded a Sloan Research Fellowship in Computer Science. Welcome, Dr. Wiens.
Hi, everyone. I'm Jenna Wiens. I'm an Associate Professor of Computer Science and Engineering and Co-Director of Precision Health at the University of Michigan in Ann Arbor. And today, I'm excited to tell you about our work on building patient risk stratification models for clinical care and share with you some important lessons we've learned along the way. So in hospitals today, we're collecting an immense amount of patient data. And in my research group, we develop and we use machine learning techniques to detect patterns in these data that can be used to sort patients from low risk to high risk for a particular adverse outcome or event, or match patients to appropriate treatments, with the ultimate goal of augmenting clinical practice and improving patient care. Given the challenges that today's healthcare system is facing, there's a critical need for such clinical decision support tools. We work on many different projects and domains across healthcare, and you can always learn more by visiting our group's website. So you can either scan the QR code here or visit the URL down here. But today, I'd like to use this time to tell you about one project in particular. A project in which we've shown how machine learning tools can be used to identify which patients are at greatest risk of acquiring an infection during a hospital stay. Healthcare-associated infections are one of the top contributors to death in the US, and Clostridioides difficile, the most common type of healthcare-associated infection, is a type of bacteria that takes over the gut when normal flora get wiped out. It can lead to colitis and death, and is associated with excess medical costs of billions of dollars per year. And we hypothesize that one of the reasons these types of infections remain so stubbornly prevalent is because we lack an effective tool for measuring patient risk. Given that the risk factors are multifactorial, we take a data-centric approach to the problem, leveraging the contents of the electronic health record to learn accurate models for predicting C. diff infections. Within the EHR, we have everything from what medications a patient is taking to where they are in the hospital and who is in the bed next to them. Our model essentially learns a mapping from the contents of a patient's EHR to that patient's risk of acquiring an infection with C. difficile during the current hospital admission. Applied to a new, never-before-seen patient, the model produces an estimate of risk each day, updating its prediction based on changes to patient health. We can then classify a patient as high risk once they cross a pre-specified decision threshold. For a patient who doesn't end up acquiring C. difficile, they must stay below this decision threshold the entire time. We developed the model on patient admissions spanning 2013 to 2018 and validated on data from over 25,000 encounters in 2019. The model achieved an AURC close to 0.8 and a positive predictive value 6 times the baseline incidence. Moreover, we showed that we can accurately identify at-risk patients 5 days in advance of clinical suspicion. Once integrated into clinical care, such clinical decision support systems can be used to guide interventions, whether it's targeted environmental cleaning or even whom to test. This in turn could lead to decreased length of stay, decreased transmission, reduced costs, and improved patient outcomes. And we published this work and this model in Infection Control and Hospital Epidemiology in 2018. So excited about the potential for impact, we set out to integrate our model such that it could be used to make near real-time predictions. But this required a shift in infrastructure. So previously, all of our retrospective analyses had relied on a research data warehouse, or RDW, that pulled data from our instance of Epic, known as MyChart, and many healthcare systems utilize a similar setup in which data are extracted, transformed, loaded, or stored in a separate database from that with which providers interact. Since you don't want complex data-intensive reporting in Clarity to impact the provider-facing environment. In addition, many academic health centers utilize data warehouses to serve up data to researchers for analyses. So we use these data for our retrospective analysis and our final model validation in 2019. But once we shifted to prospective implementation, we needed to write some custom web services to make up for the delay in the ETL process associated with some of the data in RDW. So some of the data was delayed by up to a week between when it was entered by providers to when it was available in the research data warehouse. So we have these custom web services that pull the data daily, allowing us to make predictions in near real time. And we worked with a number of programmers from the research data warehouse for this task, in addition to a clinical informaticist who helped us validate the data and precision health implementation team. So this new infrastructure allowed us to make predictions daily for everyone in the hospital. And we did this for a year while the model ran silently in the background. So clinicians did not see the risk scores, but we were computing them daily for every patient. And the goal here of this silent deployment was prospective validation. How well would the model do once integrated or implemented prospectively? And I just want to highlight the 3 students that worked on this project, Chihei Oh, Erkin Otles, and Benjamin Lee. So applied to the task of predicting which patients are most likely to acquire an infection with Clostridioides difficile during their current hospital admission, our patient risk stratification model performed similarly in 2020 to how it did in 2019. So here I'm showing 2019 in blue and 2020 in red, with the exception of a couple of months at the beginning or onset of the pandemic. So overall in 2019, the model had an AURC of 0.778, and prospectively, this decreased slightly to 0.767. Now you may be thinking, hey, that's not bad. There was a global pandemic after all, which led to giant shifts in clinical care processes. It's not unreasonable to expect a small decrease in overall performance of the model. But care processes and patient populations were not the only change. Recall, we had to rely on infrastructure that differed from the retrospective analysis. So we used, again, this pipeline for retrospective analysis and this augmented pipeline for prospective analysis. So temporal and infrastructure shift can both affect prospective performance. Validating on data extracted retrospectively from a research data warehouse from the most recent year seeks to mimic temporal shift, but it does not account for infrastructure shift. How will the model apply or perform in practice once applied prospectively to data extracted in near real time? So in practice, we'd expect differences, but to what extent? So to answer this question, after the year of prospective validation, we went back and we re-extracted the data from 2020, but using the old retrospective pipeline. So we took these data, extracted the data from the research data warehouse. This controlled for the infrastructure and allowed us to focus on the change due to time, the difference between 2019 and 2020, or the temporal shift. In addition, we compared data in 2020 through each pipeline. So the same patient population, but data extracted prospectively versus data extracted retrospectively to measure how the shift in infrastructure affected overall performance. So again, overall, the performance gap between the retrospectively validated model and the prospectively validated model was 0.011. However, this gap was not due to differences in patient populations or clinical workflows. The temporal shift was negative, meaning the task actually got easier in 2020 relative to 2019. In contrast, infrastructure shift was positive, and it drove the majority of the performance gap. So we identified infrastructure shift as a primary contributor to the performance gap. Existing EHR and associated database systems are primarily designed to support care operations. Because of this, they lack features to help with development and deployment of real-time predictive models. Now, EHR vendors are currently developing tools for the efficient and effective deployment of ML models. However, to the extent that we continue to develop our models using data extracted from databases that are several steps removed from clinical care operations, issues are likely to remain. The heart of the issue lies at the fact that when you access data, affects what you access. We are trying to capture a moving target with snapshots taken at different times, retrospectively versus prospectively. The EHR is inherently dynamic. So for example, the start and end dates of medications can change over time as the desired treatment plan changes. And laboratory result names can change as initial results lead to further testing. To mitigate the impact of these differences on the performance gap, one can update the model to rely less on such dynamic elements of the EHR. So for example, in our project, we swapped out medication orders for medication administrations. Even though order time is available earlier than administration information, orders are frequently canceled or updated by physicians, making them less stable. So while overwriting records and values in this way might be of little consequence for care operations, it makes retrospective training fraught with workflow issues. Our findings underscore the need to build pipelines that are representative of the data available at inference time. Mechanisms are needed to keep track of what the database looked like at every moment in time. However, in lieu of such solutions, thorough prospective validation and analysis can help bridge the gap, providing a more accurate evaluation of production model behavior and elucidating areas for improvement. So to learn more, you can scan the QR code by holding up your phone cameras to the screen, and this will bring you to my group's website where you can find the full paper and code for this analysis. Or better yet, you can stop by our poster. So this work on characterizing the performance gap was published this year at the Machine Learning for Healthcare Conference, which will take place on August 6th and 7th. So to find out more, you can visit ml4hc.org. I'd like to just end by acknowledging how crucial the team was to getting us to the point where we're at now in terms of students and clinical collaborators in the precision health team and support from the data office and the research data warehouse. We worked closely with MyChart developers with expertise in the Epic-based systems and many external collaborators. Thank you.
Our next speaker is Lawrence Tanenbaum. Dr. Tanenbaum is currently Vice President and Chief Technology Officer and Director of Imaging at RadNet, Inc. Prior to this, he spent over 20 years in the private practice of radiology at JFK Medical Center, New Jersey Neuroscience Institute as Director of MRI, CT, and Neuroradiology. Dr. Tanenbaum is a long-term collaborator with the medical imaging industry and chairs several advisory boards. He has interests in developing applications of AI and machine learning, contrast agents, MR, CT, and advanced rendering, and is passionate about advancing the clinical practice of medicine, focusing on patient-centric care, efficiency, radiation dose, and physiologic imaging. He is an active educator with interest in advanced imaging and innovative value-adding applications. He has authored over 100 scholarly and peer-reviewed articles, continues to chair educational and academic meetings, and has delivered close to 2,000 invited lectures around the world. Take it away, Dr. Tanenbaum.
I am pleased to have this opportunity to present this short presentation on natural language processing and understanding and the role in the imaging enterprise. We won't have much time to really set the stage here in this 10-minute presentation, but I'll touch it for a moment on where AI fits in the society and the imaging enterprise, but we're really going to focus on the natural language piece of this particular presentation. We know what AI is. It's essentially a branch of computer science that lets computers do things that are associated with human intelligence. AI has been described as the new electricity. It's all around us, and things like online advertising. It's what's behind autonomous driving, and there are many areas where computers are already outperforming humans. We know at this point that computers are better than humans are at image recognition, and they've gotten to the point where they're actually better than humans at speech recognition. Now, there are a lot of different areas where AI impacts with the world. The one we're going to focus on today really is the natural language processing and understanding part of this particular presentation. So what is natural language processing and understanding? These are techniques that aid in the conversion of text, unstructured text, into a structured representation. It essentially enables computers to derive meaning from our natural language input. Used on medical records and reports, these tools can enable automatic identification and extraction of information. And with that in mind, you can see there's a lot of different areas where this tool, NLP, can impact on the imaging enterprise, impacting on decision support criteria, utilization management by reading records, assisting in scheduling an appointment booking, things like reading the record and knowing what the previous report said, and will actually design and tailor the acquisition to what we need to do that particular day. It can actually look at what you've said in your report, even look at the images when combined with computer vision, and assist in making a diagnosis. And something we're going to focus on a lot today is using NLP and NLU to impact on the actual reporting process, reporting content, and report follow-up. So really, that's what we're going to talk about in this next few minutes. So when you think about enterprise opportunities, you look at the typical healthcare cycle. Patient comes in, sees his doctor, takes a history and physical. Okay, then makes an imaging request that goes to the wrist. The radiographer sees that request in the wrist and does the exam, picks a protocol, picks a modality, does the exam, does the acquisition, goes to the PACS, comes back to the radiologist. There's a recommendation and an interpretation, which then goes to the doctor that makes a clinical decision. Great, very smooth, very easy. Are there any opportunities for error here? Well, yeah, there's quite a few. We can do a poor job at utilization management because we haven't really looked at the record and considered that in terms of processing the imaging request. The radiographer may choose the right protocol, may choose the wrong protocol because he doesn't have access to all the records, and we can use tools to help with that. When we do the actual imaging acquisition, is the image quality where we need it to be? Is the images what we needed to obtain to answer the clinical question? And even after the radiologist has seen it, we can use a combination of natural language processing of reports and computer vision to identify errors that need to go in the report. We can even look at errors between what the report says and the way the coders interpret what's in the report, and actually look at the performance of the entire process in terms of peer review, and we'll talk about all of that. But all of these are opportunities for natural language processing and understanding in the healthcare enterprise. So essentially, natural language understanding is capable of extracting information embedded within free text radiology reports, things like the history, which can help inform the radiologist of what needs to be done, looking at imaging findings in the prior and current reports so that you can make sure that the radiologist doesn't fail to comment on the pertinent positives and negatives based on what's gone on before, and even impact on the way follow-up recommendations are made and followed up on. And again, this can easily contribute to informed utilization management, which some people call clinical decision support, by looking at all of these records. Now, again, when it comes to the actual imaging process, you can actually use what's in the record to determine what actual protocol needs to be done in any given case. This, of course, reduces the need for human engagement, someone going through all the requests, because this will increase efficiency. It makes sure that the exam is more pertinent to the questions at hand, increasing its value. When you do things right the first time through, you have fewer callbacks. And of course, that makes a big difference. And it all leads to better patient satisfaction. This is an ultimate patient-centered move, as well as referring satisfaction, because not only did you do the right exam, you commented on the key clinical question and delivered that to the doctor, and again, leading to a much higher level of satisfaction. Now, again, these tools, which can essentially read radiology reports, can be really very helpful because they can lead the radiologist to what the important actionable findings were in prior reports to make sure they're addressed in the current reports. And as I mentioned, this improves the pertinence of the report in the current episode of care. And again, it can actually take all of the unstructured report information that we put in all reports on a routine basis and actually pull out content, structure it, and this can be used for data mining, follow-up, and research. Now, when you combine natural language processing and understanding with computer vision, the typical AI image interpretation, you can then do things like compare the active report, the report itself, with what the computer sees, and avoid critical omissions in this process, making sure that they jive properly. And of course, this leads to overall quality. And frankly, when most radiologists hear about this, their light bulbs go off, their warning lights go off. Because one of the admonitions we have as AI impact on the imaging enterprise is it can't make more work for the doctor, the way, say, traditional breast CAD did in the old days. It's got to make things smoother. So frankly, if this tool was actively reading the images and reading the reports and just flagged everything that it saw, it could cause a problem. But when these things are done in a clever way, it could actually limit the flagging, the alerts, to only areas of discordance where there is something in the image that isn't in the report. So the radiologist can only focus on where the mismatches are, and this can minimize alert fatigue. A typical example, the intelligence might see the liver image lesion, and if it's not in the report, as in this example, it can say, hey, you know what, there's a liver lesion you didn't mention in your report. This is a paper I published with the folks from AIMI, where they actually looked at their lung algorithm. And this particular algorithm combines computer diagnosis, computer vision, looking for lung nodules, as well as natural language processing and understanding, reading the report, and only flagged in this particular experiment when there was a discrepancy. In other words, if there was no follow-up called for because the nodules a nodule wasn't identified, this would only flag if nodules were identified that wouldn't be followed up based on what the report said. So it's really kind of clever way of going about this, and that's from the folks at AIMI. Now, again, we have other challenges in the healthcare enterprise, and one is coding. We employ a lot of people in the coding process to make sure our reports don't get, our billing requests don't get knocked back. And if you can use a computer, which was really designed for this process, to read the report and choose the appropriate coding, you can massively reduce your staffing costs and improve concordance, accuracy, and first-time payment. Again, the same combination of tools, computer vision and NLP, can actually be used to get a more clever version of peer review and learning. And the nice thing about that is that these don't require FDA approval. You can just use this as the quality improvement measure and to make sure that things aren't being missed. Another great opportunity here is to make sure that there is follow-up, that patients return for imaging after their follow-up recommendations are put in the report. There are challenges here with these things. Radiologists tend to report them in a variable way. There is inconsistency within and between practices, and this irritates everyone in the process. If indeed you had a tool that could read the report and know the guidelines, it can actually improve the consistency and appropriateness of this practice and generally lead to happier doctors. Another thing these tools can do is can identify the fact that you asked for a follow-up in the report. That's an interesting thing because the folks at AIMI have shown that 55% of the recommendations that they look at in this large survey of 3 million reports weren't followed up on. The patients didn't come back. You can use these tools, things like Agamon that I mentioned, as well as things like White Rabbit, which actually had a very positive impact on patients returning at RadNet. They've actually produced a 25 to 50% increase in patients coming back for follow-up using these types of tools. Now, the other thing where NLP can impact on is on things like imaging reports. As you know, the 21st Century Cures Act really added some new burdens on the radiology process to make sure the reports are accessible and then readable by patients. And this is the ideal tool that can actually take a report, allow the patient to see it, even tailor a report for different types of clinicians, increasing the impact of decision-making, improving patient satisfaction, and of course, making your facility more attractive to individual institutions. And again, one of the obligations we have now is to make the reports readable for patients. It's actually relatively easy for these types of tools to add a lay summary at the end of the reports. All right, so I'm a little over time. I think I'll stop right here and say, I hope that was a reasonable survey for where these tools can be used in the imaging enterprise. I'd like to thank the organizers for having me and thank the folks that have registered for this meeting for their attention. Thank you and good day.
Thank you, Dr. Tanenbaum. Our next speaker is Mirabela Rusu. Dr. Rusu received a Master's of Engineering in Bioinformatics from the National Institute of Applied Sciences in Lyon, France. She continued her graduate studies at University of Texas, Houston, where she received her Master's and PhD in computational biomedicine, with research focused on the fusion of biomolecular structural data from different sources, such as cryo-electron microscopy and X-ray crystallography. During her postdoctoral training at Case Western Reserve University, Dr. Rusu developed computational tools for the integration and interpretation of multimodal medical imaging data in the prostate and lung. Since 2018, Dr. Rusu has been an assistant professor in the Department of Radiology at Stanford, where she leads the Personalized Integrative Medicine Laboratory. Take it away, Dr. Rusu.
Today, I'm going to talk about our work in bridging the gap between the digital pathologist and digital radiologist for diagnosing aggressive prostate cancer. So why are we looking at prostate cancer? Because prostate cancer remains the most diagnosed cancer among American men. It accounts for about 20% of all diagnosed cancers, and it accounts for 10% of all deaths by cancer in American men. In this context, prostate MRI is increasingly used to guide biopsy and local treatment. But prostate MRI has a couple of shortcomings, including the fact that radiologists can still miss cancer when they interpret prostate MRI. Depending on the cohort, the number or the percentage of missed cancer can range between 12 and 34% of lesions. In addition to missing cancer, there are also many false positives. So when we think about false positive from a clinical perspective, it means that this patient needs additional biopsy confirmation. So during the biopsy procedure, this patient will receive additional needles in addition to the systematic 12 course that is done for prostate cancer biopsy procedures. The third point here is that comparing radiologists, there is a large variation in interpretation with the kappa coefficient ranging between 0.46 and 0.78. So where my team and our research has been focused is to help radiologists interpret prostate MRI images, specifically in detecting and distinguishing cancer from benign confounders when we talk about prostate cancer, and also looking for subtypes. So distinguishing between indolent and aggressive cancers. Why do we need to do that? Is because this will help us to reduce the number of needed biopsies. So hopefully we can spare the men that don't need a biopsy for going through that procedure that involves 12 needles. And additionally, we can target the lesion, particularly important when you have lesions that have a mixed aggressive and indolent component. So being able to target the aggressive component will hopefully be able to better identify the extent and then the location of aggressive cancer, and to and then obviously this could be very useful during the context in the context of local treatment. So what my team has been doing is to develop AI methods that are focusing specifically on patients that undergo radical prostatectomy. So these are patients that have a surgery. During the clinical care of this patient, the patient will receive a preoperative MRI, so an MRI that was acquired before the surgery, and the surgery will produce a histopathology image. Here I'm showing what a whole mount histopathology image look like. We can see the extent of indolent and aggressive. And in this context, these two labels are coming from a pathologist. Yet, this could also come from a digital pathologist, and we'll talk about this in a second. Our approach involves taking this whole mount histopathology images and registering them with the MRI. So that's what we do in step number 2, to create a mapping between the pathology and MRI, one, to get the labels. So we see now that the red and blue outlines are projected onto the MRI of the prostate. And then the third step there is to use these labels in order to detect cancer on MRI. So why do we want to go and use this pathology images? Well, because as I said already, some of the radiologist lesions or lesions outlined by radiologists have shortcomings. One, some of the cancers are missing. Not only that, but also because cancer can have a very subtle appearance, there is a large variation in the extent of cancer, even when these lesions are all outlined. So we see here on the left side, outlined by a radiologist. So when we look at the ones coming from pathology, we can see that the borders are quite different than the ones from radiology. And also radiologists quite often are missing lesions, like the ones showed here in blue. This is not maybe such a big problem when we are talking about patients that undergo surgery, because this prostate will go out irrespective whether there is 1 or 2 lesions that has been found in this patient. But this patient won't be eligible for local treatment if the cancer is present on both sides of the prostate. So with that in mind, let me tell you a little bit about how we go about labeling our pathology data and why do we want to use the digital pathologist. So in this particular context, we have been using deep learning methods to detect Gleason grades. This is the information that is used by pathologists and clinicians in order to characterize the type of prostate cancer, and I essentially distinguish the aggressive from the indolent cancers, or indicate whether this is an aggressive or indolent cancer. So in a perfect world, we would want to be able to have human annotations of all these different types of cancer, but that's a very, very tedious process for a pathology. So here we see a whole mount histopathology images with multiple outlines. I'll go one by one through what we are seeing to discuss some of the advantages of using a digital pathologist, which is what we call here, which practically is only a deep learning network that has been used to detect the extent of the different Gleason patterns on these histopathology images. So in blue here and green, we see, so the fill colors are the ones coming from the digital pathologist. This is the these are the results of the prediction of the deep learning algorithm. When we see the black outline, like the ones that we are seeing here, those are coming from our human pathologists. So we can see there is quite a nice concordance between what the human pathologist and what the deep learning are actually detecting, with some differences still. And then what we see, for instance, in this image in the yellow, is we see the extent of cancer that, again, same human pathologist at a different time has outlined, indicating that this is Gleason pattern 3 or Gleason score 3+3. As we can see, there is a huge difference in how that cancer is being outlined between the different whether that's the human or the digital pathologist. So similarly here on the contralateral side, we can see the differences between what the digital pathologist, blue and green, are showing relative to what the human pathologist has outlined. So when it comes to training deep learning networks on radiology images, we need a ton of labels from pathology. So for a human to do all these outlines is very, very tedious. So in our work, we are using this deep learning method to get labels on pathology images. Once we have the labels on the pathology images, now we can register our data between the pathology and radiology images in order to map those labels and be able to create labels of cancer with aggressiveness onto the MRI. So specifically here, I'm showing the framework that we are using, which was developed by Wei Xiao, a postdoctoral fellow in my lab, that shows how we go about registering corresponding histopathology images and MRI images. So there is a neural network, in particular, a two-step one that does, as in the traditional registration method, solve the problem of an affine optimization and a deformable optimization. These two networks are relying or extracting features using VGG16. And then the regression part of the network is essentially a suite of convolutional layers followed by a fully connected layer that will allow us to detect the parameters of those transformations. The advantage of using deep learning for registration methods is that we can use not only medical images, but also natural images for the training, which is what we have done in this work, and show that we can generalize that this results, the registration generalizes quite well between different cohorts that have pathology acquired with different parameters. So without going too much into the details of here, the advantage of using deep learning at this step is the fact that we can do this registration a lot faster. So if you want more details, check out the paper of Wei. So finally, once we have this label and we have this mapping between histopathology and MRI, we have developed multiple approaches, but today I'm only talking about CoreSignia, which is an approach that focuses on a two-step procedure that allow us to not only use the labels that we have from pathology, but actually using the pathology image. And then after we learn a correlation between the radiology and pathology images at the pixel level, we can use those correlations to create what we call MRI biomarkers. So essentially develop different representation that are derived from the multiparametric MRI, and those are going into a deep learning network, allowing us to detect on a per pixel basis whether we have aggressive or indolent cancer. And here I'm showing some examples of how these biomarkers look like. They tend to essentially be a linear combination of features derived from T2 and ADC. And then this linear combination, there are multiple linear combinations that can be derived and then can be used. Using this approach, we are able to quite reliably detect the extent of aggressive and indolent cancer in this patient, and also have pretty good results in the patients that have a negative MRI or they don't have prostate cancer. So with that, I will conclude by saying that we show that registering radiology and pathology images allows us to create a pixel level correspondence between these multimodality data sets, that it allows us to get not only cancer labels and also aggressive cancer label, but it also allows us to have image intensity correspondences. And with that, we can certainly train deep learning methods that are able to detect aggressive and indolent prostate cancer. This will allow us to essentially identify the aggressive component within prostate cancer where aggressive and indolent coexist, hopefully one day reaching the level where we can use this in clinical setting to guide biopsy and local treatment. So with that, I'll thank my team, specifically 3 people, and Arun Sitaraman, which was a master in my lab, not shown here, and then Indrani Bhattacharya and Wei Shao, which are 2 postdoctoral fellows working in my lab. I'd like to thank our funding agency and collaborators, and opening this for questions if there are any later on.
Thank you, Dr. Rusu, for that wonderful talk. And thank you to the panelists for the information and science that you presented today. We still have a few minutes for the panel discussion. So it's going to be a mix of questions from the audience, as well as some questions that I had focusing on the impact of AI. So for Dr. Fries, one question that's come up quite a bit, or 2 actually, are number 1, does Snorkel have any, does it address interoperability? And is there any thoughts about integrating it into into different ideas like FHIR, which is a way to integrate multiple EHR models? Will people be able to use Snorkel with FHIR APIs, et cetera? And another thing that people are wondering is how training, using this for training data will impact FDA approvals.
Yeah, those are a lot of great questions. I mean, Snorkel is a piece of open source software, so there is no sort of direct support for interoperability into sort of the big EHR standards. There are absolutely research projects that use ideas influenced by Snorkel to do things like data cleaning or data fusion. And so there is active research in that area, but it's not quite like a production-ready product where you could download. There's certainly research APIs that may be enough to sort of spin up some preliminary work in that area. In terms of FDA approvals, that's a whole area of discussion that I would not consider myself particularly suited to answer. But I do think Snorkel as a technology does suggest sort of interesting ways to generate consensus, right, in the presence of noise, in the presence potentially of bias. And so there are lots of interesting ways to think about what's ground truth. Well, we need a principled way to argue, why we're making some decisions or why we're synthesizing opinions from different people. And something like Snorkel, I think, is an argument for why that technology is important to think about.
Totally agree. Dr. Wiens, you presented excellent data on how your C. difficile model performed at your institution. So I don't know if you're aware of the paper by Andrew Wong and colleagues where they looked to validate a proprietary sepsis model that Epic built and found at the University of Michigan, using patient data specifically from there, that the model did not perform very well and potentially could generate a lot of alerts that were not that helpful for physicians. So questions I have for you are, number one, are there any thoughts to the timing of when you would have your models alert physicians to potential C. diff infections, thinking about how to avoid alert fatigue? And number two, how do you work with Epic when you might build models that perform better than what they have in their proprietary system?
Great questions, Elsie, and thank you so much for inviting me to come and speak today. I'll talk about your second question first in terms of how to build or improve upon the Epic models. So I am aware of the work that Michigan did on the sepsis model. We've done similar work with the Epic Deterioration Index. And we have work in submission right now looking at how we can improve upon those models using data from Michigan. And that highlights, again, the issue of retrospective development and validation versus prospective validation. So to improve upon the Epic Deterioration Index, we use data from the research data warehouse. But you have to acknowledge the differences between how those data are curated and processed and stored versus how the data are going to appear live in the EHR. So understanding the performance gap, measuring the performance gap, and then the contributors, temporal shift versus infrastructure shift. I just want to drive that point home, how important it is to measure. With respect to the C. diff model and integration into clinical care, our plan right now is not to show it to all providers. So while we have scores that are being generated on a daily basis for every patient in the hospital, those scores are not available to all clinicians at the hospital, but they are available to the infection prevention and antimicrobial stewardship teams. And working with those teams, we're identifying a bundle of interventions, so not just one intervention, but multiple interventions that we believe will help to effectively reduce the incidence of C. diff infections.
That sounds like an excellent solution. Another question for Dr. Tanenbaum. Your talk brings up a lot of maybe even anxiety about how AI will interact with healthcare jobs. So I wanted to ask you how you conceptualize how AI will impact radiology and the jobs like the techs who are doing a lot of the work that now some of these NLP systems will be able to do. Do you think of it as synergy, replacement, or some other paradigm?
Well, not to start with the scary part, but certainly when you look at the impact in coding, we hope to be able to employ many fewer human encoders. There's plenty of opportunity throughout the healthcare enterprise to put those people to better work than doing things as simple as matching report content with the appropriate coding. I don't want to be the poster child for eliminating jobs in the radiology sphere, and I think for the most part, radiologist jobs have held very steady despite the innumerable AI concerns getting started and making an impact on the healthcare market. We've certainly seen the boost in quality that things like computer-assisted detection has helped with in both university and practice settings. I think that for the most part, we are talking about a technology, for the vast majority, almost completely, a technology that will simply refine the process, make it smoother, remove the drudgery, improve the quality and consistency, and leave net jobs intact. Although there may be some reassignment. I don't think that philosophical statement is novel to what I think. I do think that the use of NLP, which is really what I came and focused on, is only going to improve the processing. reduce the redos, reduce the recalls, reduce the irritation of mismatches between what is really necessary and what is actually done. So I'm bullish on going into radiology, whether you're a radiologist, a technologist, or front or back office administrator. I think there is plenty of opportunity and very limited downside to integrating AI tools like NLP in day-to-day practice.
That's wonderful. And with 30 seconds, Dr. Rusu, there's a lot of disparities in prostate cancer outcomes. Do you think your models will be able to address this?
That's a very, very good question. That's our hope. And our studies are starting to focus on looking more at disparity and looking at clinical variables and factors that can predict the outcome of a patient. So my hope is with this, we will be able to have a very objective kind of way of looking at the MRI images and hopefully with it helping at least understand and then reduce some of disparities between different populations.
Awesome. Thank you guys again for joining us today, and thank you to the audience for taking the time.
Thank you.